Good morning. Happy New Year, everyone.
So how are you?
And
Good morning.
yourself? Good morning.
Everyone's a little Happy New Year'd out, I think. There's just the two of us here in person so far from the committee. And I don't know who all we're seeing on Zoom. I guess nobody yet, right? No. Joseph heard me apparently. Joseph says, thank you, Erwin, for taking the minutes.
Copy. Someone else said hello.
Yep. Thank you, Erwin, for taking minutes today for us. Okay. Liliet says, Happy New Year, everyone. That's Liliet Lopez. Rosie, I'm so sorry, this delay is killing me. Let's see. But all these participants, let me see what I can do. I got to get rid of this out here. Hey, Richard. Zoom also. Let's see, on this one here. Okay. Bless you. Just FYI, Joseph it usually does is take the minutes and, do them however he wants to do them. And then he sends them to me for editing,
Okay,
so you can, just do that one,
and then I'll.
and not a rush.
Okay, got it. I'm actually following. Downloaded one of
Yeah, the
his
minutes,
previous ones,
Yeah,
and I'm trying to follow the same structure, and then I'll send it to you.
no problem. Don't worry about the attendance. I got it.
Okay, you already
I
have,
usually
alright,
keep track of who's on Zoom and who's, who the other folks are
got it.
and where they're from.
I'm here, Miriam James.
Sorry? Oh, there you are. Hi, Miriam.
Hi.
Hi.
Okay,
You
Happy
got
New
2
Year.
for 1 here.
I see you both in the same picture.
Yep.
Lovely photo. Makes a lovely photo of the two of you.
Yeah.
Okay, so being aware of, and, concerned about everyone's time and especially our presenter who has agreed to present to us today. Ebenezer, I'm going to call this meeting to order at 10:45 a.m.
Good. We are recording. Everything is in order.
Okay. Set to go?
Yes, Mary, you are all set to go.
Okay. So good morning, everyone. Happy New Year.
Good morning, Happy New Year.
Sorry.
Good morning and Happy New Year.
Morning, everyone. Happy New Year.
Morning.
Calling this meeting to order of the Community Board 12M Committee for Concerns of the Aging. This is a hybrid meeting, and we are in person at the Community Board Conference Room on West 166th Street on the 6th floor. This is Thursday, January 2nd, 2025. Hopefully I can remember to make that 5 from here on. So, just to briefly start with introductions. My name is Mary Anderson, and I'm the chair of this committee, as well as co-chair of WICOA and president of the board of directors at the Star Senior Center. And the other person that's here in person at the moment is Erwin Fernandez to my left. And he is a member of this committee, as well as
Public Safety Committee.
Public Safety Committee on Community Board. And I would appreciate his efforts, and Erwin will be taking the minutes today. I have several of other members of the committee on Zoom. I'm going to just quickly run through. Joseph Kolinsky is the assistant chair. He is not
Yes.
able to be.
Good morning, everyone. I'm here on Zoom today. Happy New Year.
Thank you for being on Zoom. Dory,
Good morning, everyone. Dory Garcia, Executive Director of ARC 16 for Washington, Co-Chair of WICOA, and a public member of this committee. Happy New Year, everyone.
thank you. Richard, Richard Allman, are you there? All right, Carol,
Everybody, Happy New Year. Public member of this committee, Director of Dykeman Older Adult Center,
and your name is
Carol Weeks.
Miriam.
Miriam Rabner.
No,
MJ.
Miriam James, I'm sorry. Sorry, Miriam, trying to get the committee first.
Good morning, everyone. and Happy New Year. Mariam James.
All
Did you-
right,
You heard me?
yes,
Okay.
Miriam, okay. So now Miriam Rabner, I'm sorry.
Miriam Rabner, MJHS Hospice and Palliative Care, New York City. Executive Board member of WICOA and a community member for this committee.
Thank you. Liliette,
Liliet Lopez, NICONEX Outreach Specialist.
wow, I don't know what happened there, but anyway, welcome Liliette. Shuli,
Good morning. Happy New Year to everyone. Shuli Gottman, Director of Mariah Senior Center, and I'm on the Executive Board of WICOA.
Mary, can you hear me now?
yeah, we were able to hear you before, but it got kind of,
Like a feedback.
Wow.
Liliet Lopez, NICONEX Outreach Specialist, and wishing everyone a happy new year. Thank you, Mary.
there you go. Thank you. Okay, now have somebody Mastio Raysor. If you're able to speak, you should be able to. All right, and Cecily Mendez, I believe?
You hear me? Do you hear
Yes.
me?
Yes, yes.
I'm here. Mayfield
Okay.
Raven,
Where are you from,
Community
Matthew?
member.
Sorry. Sorry,
community member.
Community member.
community member. Okay, thank you.
Good morning.
Thanks for coming in. Hi, Liz.
Thanks, everybody.
And Cecily Mendez, are you there?
Hi, yes, good morning. My name is Cecily Mendez, and I'm the current outreach specialist for the Neighborhood Shop Elder Justice Program. And so it's my first time taking place in one of these meetings, but thank you so much for welcoming me. Happy New Year's to everyone.
Thank you for being with us. Did I pronounce your name correctly?
Yes, thank you so much for that.
All right, I've been working on it for a couple of days, okay? Ever since Lawanju sent me your name. All right, so without further ado, Liz Ritter, another one of our committee members, has just joined us in person. Thank you, Liz, for coming, and Happy New Year,
Thank you.
as I've said to everyone
Do we not
else.
have the Zoom up on screen?
I don't know.
Because I
Yeah.
can't see the meeting, so that's a little weird.
Yeah. We're not-
I'm not sure, I'll figure, I can call him and maybe you can guide me through.
Ebenezer, can we see the screen? There isn't going to be the presentations on Zoom,
Oh,
so there's no PowerPoint or anything.
well, all the more
But-
reason why it'd be nice to be able to see it,
Right,
but,
exactly.
okay. And
Okay, gracias.
And you save?
Hmm?
You save?
Got a bunch on Zoom.
Okay, cool.
Oh, we have the screen?
Yeah, it's ready. I forgot to, I put it too early. I was waiting for you.
Oh, okay.
And I forgot to turn it.
No worries. Okay, so Rosie, why don't you go ahead and get started with our presentation? So our presentation is Accessing Healthcare Resources with Basic Serious Illness. Rosie Bernard, I'm sorry.
Rosie
I'm
Bernard.
here. And appreciate you coming to join us, even though you're still on vacation. I didn't realize.
It's
You know,
okay.
I sure do
you.
appreciate that.
So much better.
So,
For you,
welcome,
for you, anything, Mary.
welcome, the floor is yours.
Thank you. Thank you, everyone, and good morning. Happy New Year. I hope this year be a better year than last year, whatever that means to you.
Yes.
Okay.
It's,
So-
it's a, hold on just a second, there's some kind of like vibration.
No, the speaker seems to be going out.
Yeah. Sorry, we're just, everybody who's coming in over Zoom sounds like they're talking underwater. It's on, the problem is on our end, not yours. Can somebody in Zoom land say something to see if,
Something?
yeah, no, still waffling.
Yeah.
The hour.
It sounds almost like it's vibrating on what it's resting on. It seems like it might be a mechanical problem, not an electrical problem.
Yeah, sí.
Buenos días. Bienvenidos.
No, Gladys está allá al lado.
De nada.
Yeah, it sounds like the speaker is going bad.
Okay, I guess we'll just suffer through it. Never mind.
Rosie, go ahead.
Okay, no problem. That's the beauty of technology. It works when it works. So Marcel, if you can mute myself so like that, there's no background noise. So I'm from MJHS, Metropolitan Jewish Health System, and MJHS has been established for over 100 years by the 4 Brooklyn ladies. The range of our health services include home care, hospice, and palliative care for adults and children, rehabilitation and nursing care, such as Isabella, which is in Washington Heights, and Menorah, which is in by Manhattan Beach in Brooklyn. And we also have a research-based center, which is called the MJHS Institute for Innovation in Palliative Care. We also offer health plans for Medicare and to eligible individuals known as Elder Plan and Home First. Okay. And today, like I said, we're going to talk about basically what is hospice and palliative care and what is the difference. So the advantage of hospice and palliative care is that they both aim to relieve symptom burden and are delivered by interdisciplinary teams. They both address the needs of the patients and family. And all hospice is palliative care, but not all palliative care is hospice. So in other words, all palliative care can be all hospice is palliative care because hospice is in a sense is specialized palliative care. But just because someone has palliative care, just receives palliative care, it does not mean that they qualify for hospice. Okay? That's basically what that means. In a sense, the national consensus definition of palliative care, it seeks to prevent and relieve pain and suffering and ensure that the highest possible quality of life, regardless of the age of the individual, the stage of an illness, or a life-limiting illness. Okay? So palliative care is specialized medical care for people living with illness. This type of care focuses on providing relief from the symptom and stress of the disease. The goal is to improve the quality of life for both the patient and the family. Palliative care is provided by a specialty trained team of doctors, nurses, and other specialists who work with the patient, other doctors to provide an extra layer of support. Palliative care is based on the patient's needs, not the patient's prognosis. It is appropriate at any age and at any stage of serious illness and can be given in conjunction with curative treatment. When a person receives palliative care, they do not have to abandon treatment that could cure serious illness. Palliative care can be provided alongside curative treatment and can start from the time of diagnosis. Now, what is hospice? Hospice is an additional layer of services, again, for individuals of all ages who have life-limiting illness and that is no longer responsive to curative treatment. Okay? Hospice is a benefit from Medicare, Medicaid, and commercial insurances. And patients who are eligible for hospice may choose to enroll or not, and those who enroll may quit the program at any time. Okay. Hospice is centered on maximizing comfort and quality of life through the reduction of pain and suffering. Being eligible for hospice does not mean that a person is imminently dying. Patient and family can get the full benefit of hospice care by enrolling early. Sometimes people really wait to enroll in hospice when the person is already dying, and they're not able to take full advantage of the hospice benefit, which can be helpful very early on this illness. I forgot to mention before I continue that my colleague Miriam Ronners is here, and just in case I missed something, she also will help me. Okay. So just to continue, the eligibility for hospice is that a hospice physician will evaluate the patient's condition. They will review the patient's treatment and make a judgment about whether the person meets a requirement for hospice. Experiencing progressive declines in nutrition, function, and cognition in the past 6 months. It could be that the person has a terminal diagnosis, such as cancer, end-stage renal disease, end-stage cardiac disease, end-stage pulmonary disease, or late stage of Alzheimer's disease, or any dementia disease, really. Now, so let me just clarify, to be eligible for hospice, basically, a physician will evaluate the patient. They will look at the whole prognosis and the patient's condition. And one of the criteria is that if a doctor gets a prognosis that if an illness was to take its natural course, that is most likely the person may pass away within the 6 months. It's possible that the person may be eligible for hospice. Okay, everything is on a case-by-case basis. But I would suggest to always, if you think this person may be eligible, always make a referral either for palliative care or for hospice. Okay. In terms of the interdisciplinary team, upon admission to hospice, patient is assigned to a team of professionals where a hospice physician will monitor the care, order treatments, work with the patients or the physicians if needed, and visits as needed. A registered nurse who will visit the patient 1 to 3 times each week, a social worker who will visit the patient 1 to 2 times each month, always on a case-by-case basis. A chaplain could reach out either by phone or visit in person if the person wants. If needed, a home health aide can help with activities such as bathing, dressing, and it's typically provided by the hospice for 3 hours per day, 5 days per week. Hospice can also arrange for visits by a physical therapist, occupational therapist, speech and swallow therapist. In, excuse me, nutritional consult if it's needed, depending on the need. Other services, hospice may provide most supplies, such as wound care supplies, bandages, equipment such as hospital bed, wheelchair, commode, and oxygen if needed. The hospice nurse can evaluate and let the patient and family know what will be covered. Patients and families enrolled in hospice are given a number.
Paris.
Oh, there we go.
Okay.
Can you hear me?
Yes, but yeah.
So Erwin Fernandez speaking here. I have a quick question. So if hospice determining whether somebody qualifies for hospice is decided on a case-by-case basis, whether those nurses can visit weekly or the social workers would visit monthly or the home health aides can come 3 hours per day and 5 days a week, does that change at all? Because if it's let's say
No,
one
you
person
get more services.
you get that. That's what I'm thinking. So can they visit more frequently than that, or can you get more like attention from a home health aide that the ceiling isn't 5 days a week and 3 hours per day, but it can be expanded. There can be hours.
In terms of the doctor, the nurse, or the social worker, that's as needed. In terms of the home health aide, there is some kind of limitation because the home care, the way it is, there is some kind of limitation. You most likely will get about 15 hours. 15 hours, is it, Miriam? Am I correct? More or less,
Yes, and if a patient is at home, receiving hospice at home, which most patients opt for,
right.
The caregiving burden really falls mostly on the shoulders of family members or on privately hired aides, in addition to the 15 hours max that hospice will provide. So if a patient is in a nursing home, the care there will be provided by the nursing home staff. And additionally, as an extra layer, hospice staff will come in and will coordinate the care for that person with the nursing home staff. But at home, we want to be very, very clear. At home, the caregiving burden falls mostly on family members and or privately hired aides.
If you remember that I said at the beginning, hospice and palliative care are a layer of support. So it's an additional support that is provided. Did that answer your question? Nope, you muted. But I saw you say yes. Okay. All right. Anybody else has any other questions?
No, we're good.
I don't know.
Going.
We're good.
Okay.
Okay.
All right.
So hospice has 4 different types of levels of care. The first one being routine home care, which, as Miriam explained a little bit of it, it's when a patient receives care where they reside, wherever they live. Okay, so usually at home, right? It can also be at the nursing home. That's also part of routine home care. Okay. Then there's general inpatient level of care. And that's when sometimes a person living at home or in a nursing home who is receiving hospice services needs acute care. So usually in a hospital. In most cases, hospice will provide access to inpatient hospice care when this happens. So the person will go to a hospital because they need acute care. Once they get better, they will go back to where they used to be, either home or the nursing home. Okay. Then there's another level of care, which is continuous care. And that's if acute care can be safely provided in the home. Hospice will also try to arrange this if the patient or family agrees. So that means that this is just provided temporarily. If acute care doesn't necessarily mean that it needs hospital care, but it's acute and needs an extra, to be watched extra, continuous care gets put in place. Then there's respite care. This respite care is for families who are taking care of a family and maybe they are experiencing a period of exhaustion, or they simply just need to take care of something for a few days. Like the patient could be put into a facility for 5 days, so the family can take care of what they have to do or get some rest, and then that care can be provided at the facility, and then once those 5 days are over, the care can continue back at home. Okay. And this respite care can be provided once per benefit period. Okay. I any questions on that?
Respite,
Respite.
RESPI.
Thank you.
No problem. But sometimes I get a question that if respite care can be provided if a patient is not in hospice, the answer is no. That the respite care can be provided for the family when a patient is in hospice. I know that there are many different services out there for caregivers where they could get respite care, but it's slightly different in hospice. Okay. It's for family when the patient is actually at home. Okay. Any other questions?
Seeing none.
Okay. I
Rosie,
made it
one
very
comment?
short and sweet. I also very, very, very short and sweet. I don't know if Miriam, you would like to add anything? I just want you to know the difference really quick, like what hospice was palliative care. Is anything you would like to add, Miriam?
Thank you, Rosie. I think that.
No, I
just
think
wanted
she's
to-
asking if Miriam wants to add something.
Huh?
She was asking if Miriam wanted to add something.
Yeah.
Add Miriam.
Miriam?
I wanted to say that MJHS is a not-for-profit organization, first of all, and I also wanted to speak a little bit about palliative care, how it can be accessed. Till now, it was not so prevalent in hospital settings or even in clinical encounters between physicians and patients. During the pandemic, there was an increased need for palliative care. Palliative care can also start and is most accessible in a hospital setting already. So if a loved one or you yourself are hospitalized and you have symptoms that are very difficult to bear, either the medicine or the treatment is giving you diarrhea or constipation or a rash, it is incumbent on you and to advocate for yourself and to say, I need to have these symptoms managed, or my pain is out of control, I can't manage, and may I be seen by a palliative care team already in the hospital setting. So it's not limited to an outside service, but it can start and is most accessible and most available within a healthcare setting, especially in the New York City area. once you are discharged either home or to a rehab center, the palliative care can also be provided. And there are more and more freestanding centers and also physicians who specialize now in the last 10 years in palliative care. And palliative care, as Rosie said, is very often confused and is scaring people. They think the end is near, the end is near. It has nothing to do with the end of a patient's life. And it also is very supportive, not just of physical symptoms, but of emotional and spiritual symptoms. And the palliative care specialist has to discuss treatment options with the patient and the family, and has to discuss one treatment versus another treatment. So a patient has the knowledge and the insights to make a decision that works for them, time-wise and also symptoms-wise. And once the palliative care support is exhausted because an illness or a chronic illness or serious illness continues, then a doctor, a palliative care specialist might say, we have exhausted the support that we can offer now. We can no longer clinically cure you, but we can care for you. And that's when there is the switch to consideration for hospice care.
Mhm. Got it.
Thank you. Thank you, Miriam.
Thank you for that continuing clarification.
Yes.
Yeah, because it's always kind of been a question in the back of my mind. What's the difference between hospice and palliative care? And you've both answered that so thoroughly.
I just wanted to add one more thing, because we need to be very honest with our patients and you with your clients when you share information. Palliative care is a consultative service. There may be a copay, as if you're going to a cardiologist or a nephrologist or a lung specialist. When you meet with a palliative care physician or team, they may ask you for the copay, as if you went to another specialized care provider. Whereas in hospice, if most commercial insurances, Medicaid and Medicare, will cover all costs of clinical care that is related to the hospice diagnosis. So if you want to have your toenails cut while you are in the hospice program, that is not going to be covered by the hospice benefit. It is covered by your Medicare. The foot doctor will bill Medicare and will get reimbursed, but the hospice benefit only covers expenses that are related to the hospice diagnosis.
Thank
you. Ebenezer, can you promote Diane Ashley, please? There used to be a way that I could do it, but I don't see it on the screen. Huh?
Meantime, I put my contact information in case of anything that I might have. You guys have any questions or anything?
Are you not a panel? Are you a? Oh. Yeah, you're not a host. All right. You have to be a host in order to have the ability to promote people.
Ebenezer, are you hearing me?
What do you want promoted?
Yes,
And-
yes, Mary, what do you need?
Promote Diane Ashley to panelist,
Please.
and can you make Mary a co-host?
Mary is a co-host already.
Star? He says you're a co-host already. Can you see him now? See him now? You don't have to move. Having this.
Mary, what do you need?
Diane Ashley to promote as a panelist.
Okay.
She wants to add to the dialogue. And there she is.
Hi, can you guys hear me now?
Yep.
Yeah.
Oh, terrific. I'm sorry, I don't know why the camera isn't working, but I apologize. Thank you, Rosie and Mira.
It's okay, we're having trouble with I just promoted her. Okay, thank you.
Just a couple things about the hospice program. One, we are not for profit, as Miriam said, which means that obviously we're putting the interest of patient, but also the patient as well as the family ahead of all. We put a premium on providing support and education for both the patient and the family, and understand that, as was referenced, a lot of the burden does fall on the caregiver. We hate to use the word burden, but a lot of the pressure and the weight falls on the family member or the family caregiver. So we provide resources. We have video resources that people can go to on our website, not just people who are patients under our care, but anybody can go to get resources. We continue to build out that library. It is currently in English. This year it'll be expanding into Spanish. As Rosie said, to be certified for hospice, you have to have a prognosis of 6 months or less if your disease takes its natural course. You have to make the decision to forego intervention or aggressive treatment for your disease. That doesn't mean if, for instance, if you have cancer while you're on hospice, you can't receive advanced treatment to try and address the cancer diagnosis. But if you had an appendicitis, let's say, you absolutely could go to the hospital and be treated for that because it's not part of your diagnosis. As Jimmy Carter very artfully showed and led by example, while the prognosis needs to be 6 months or less to go on hospice, and far too many people come on last days or weeks, you get recertified. You are reevaluated over the course of time. It is not like we turn off the switch at 6 months. Jimmy Carter lived on hospice for well over a year. So as long as the doctor has that expectation, doctors are very good. They are not God. As long as someone continues to meet the criteria, they may remain on the program. Every blue moon, we have somebody who graduates off the program and comes back later. They do better. That happens with some of our pediatric patients. But hospice is an extraordinary benefit for both the patient and the family, and does not stop when the patient passes. We provide 13 months of bereavement support for loved ones. It doesn't just have to be immediate family after the passing of the patient. So we are really there as a resource. We are there to provide support, education, helpful tools and tips, alleviate the pain and distressing symptoms that may be there, and to really facilitate family conversations, facilitate quality of life. And there are no guarantees, and we certainly can't promise it, but without being administered, chemicals that are attacking your body, and with the increased support emotionally and family involvement, patients live the same or often longer if they're on a hospice program. There's a myth that if you go on hospice, that somehow you are going to, that we will end your life, or that it will end your life sooner, and that's actually not the case. The quality of life that it brings joy and memories to families, helps people resolve sticky situations often with our guidance and support. We can provide that. We also provide culturally specific care at end of life. We provide care for veterans that acknowledges past trauma at end of life. So there's a lot of specificity that is there. Don't want to take too much of your time, but just wanted to build out the program a little bit more for you.
Thank you,
Thank you,
Diane.
Diane. I appreciate that.
Any other questions or comments from anyone? Seeing none. Thank you so much, Rosie. Again, appreciate you coming in on your day off and not coming in, but coming on and giving us your time and your expertise to present this very interesting, very close to home topic. All right.
Thank you. And thank you both, Mayor and Diane, for helping me.
Thanks a bunch. I'll see you soon.
Thank you, Rosie.
You can certainly stay on if you like. All right. Moving the agenda, old business. Anybody have anything old business that they would like to talk about?
I actually do.
Okay.
So a couple of meetings ago, we had talked about doing some kind of resources fair in the plaza. And I feel like it's January, and to do a good job on something like that, you know, that's not something we're just gonna pull out of our noses in a couple of weeks. So especially since we have a little time, does it make sense to kind of wrap our heads around what that might look like, when exactly we would do it? Because I'm thinking to do that in lieu of either our April or our May meeting. And have like our meeting outside and do a fair from like 10 to noon or something in that little plaza nearby, and that would be the meeting.
That's what, right, we had definitely talked about doing that. And what I would like to do before we actually set a date is check with the DA's office and see what they have up their sleeve, because they did that older adult big health fair on the second floor last year. And I can't remember what month it was that we did that.
Okay.
So that we don't
jump
into each other.
Well,
you know,
co-planning an
that's
event,
laps, but
co-planning an event would be great, but I love the idea of an outdoor event and really using that plaza.
Oh, yeah.
Because it's such a nice venue, so I guess I'm also kind of wondering for the folks out in Zoom land who are representing institutions, that would be all the MJHS people and Richard from his senior center.
Yeah, we've got some senior center folks.
Other folks who are with senior centers, if they have thoughts, if they have programming they'd like to provide, if they have services that they would be able to provide, you know, tabling literature. One of the things that occurs to me about hospice, you know, my mother died in hospice in 1986. My grandparents died in hospice in 1998 and 2003. My uncle died in hospice last month. So very familiar with hospice. And I think we don't talk about death enough in this culture. I think death really freaks people out. Nobody wants to talk about it. And then, you know, when people are clearly nearing death and in this culture of, I don't want to talk about it, there's all kinds of services that could be available to them and could make their transition and their death much less terrible, much more comfortable, much easier on the people who are left behind, but nobody wants to talk about it. So I personally think it would be great if MJHS came and tabled about that and like, hey, it's a beautiful day out. Let's talk about death, shall we? You know, I just, like, we have to.
We would welcome the opportunity and do it pretty much every turn to speak about hospice and the benefits. I can't
we can
agree
also-
more that it's a taboo, you know, it's treated like a taboo subject where it should not be. And it is, I mean, I personally, you know, you've obviously had this many family experiences. I know I've had two close friends. One was being treated at Sloan Kettering, was basically told after months and months, if not years of treatment, on a Monday that there was no more they could do. She was gone Friday. I don't believe that Sloan Kettering didn't know sooner than that, personally. I think that doctors are reluctant to talk about it with patients for a variety of reasons. Patients and families either don't know it's available or don't bring it up. People don't really get to benefit, if you will, you know, get the value out of hospice if it's only a couple of days, because you're really in the onboarding process. And often when people have just gotten that diagnosis that there's really no more that can be done to cure their disease, they're in a bit of shock, even though they may have known that was coming. So those first couple of days, it's hard to digest everything. But if you can be on hospice for months, if you can be on hospice for 6 months, or again, in the case of former President Carter, for over a year, you are getting these extraordinary benefits and support system and psychosocial support and legacy projects. And, you know, if it's in the case of a, you know, people who've had trauma, I'll give an example of Holocaust survivors. The children don't want to talk about anything in terms of in front of the elderly parents because they've already suffered so much, or grandparents, they've already suffered so much. But the elderly grandparents already know what's going on, because most people usually do. And they say, don't say anything to my kids. It'll just make them worry more. And the secret keeping is a barrier to building bonds and sharing quality time. And so we really work to help bring that back. We bring in music therapy. We bring in art therapy to help, you know, bring music therapy to help engage the patient and the family. We bring in art therapy, particularly in the case of pediatric patients, so that we can help them express their feelings. Or if they're a young child, but their parent, you know, we always think of people on hospice as being in their 80s. You know, we have parents of young children who are on hospice, and art becomes a way of expressing one's feelings. So it's really about dealing with both the physical and psychosocial needs of both the patient and the family. And so, yes, we would, obviously I'm passionate about it. We would welcome the opportunity to talk more about it.
Let's normalize talking about death, please.
Yep.
And also about advanced care planning. You know, even before a person gets sick, it's important to actually talk about what are your wishes? What exactly do you want? Who do you want to speak for you in case that you can't? You know, all those things are also important. Because just like we plan, like I always say, just like you plan for a birthday party or for, you know, a baby shower, it's also important to prepare for when you're not able to talk, and when you're not able to make decisions. Make sure that you speak with your loved ones, whoever is your circle, about what's important to you. And you know, that can include for, please do not put me, don't put me in a ventilator, or yes, I want to you know, make sure that you always do my nails. You know, it could be, it range from different, so many ranges, like from little things to very important things. So it's just important to talk, and at least, I always say, at least talk to your loved ones. But if preferably, go the extra mile, do a health card proxy, do a living will, you know, do those type of documents, along with anything else that you feel that you need to in order to prepare.
Right.
It's
And our
always better to
palliative
be
care team,
okay.
I'm sorry, Rosie, just really wonderful point you're making. I think, our palliative care team, any members of our team can really help you if you need an advance directive, or a healthcare proxy. So, you need to fill it out, but we can help guide you. We can get you the right documents, et cetera, et cetera. But anybody can access these documents. It's really important. It's not always a terminal illness. You could have an accident. You could, something could happen that's emergent that you do not expect. And if you don't have those documents in place and you can't speak for yourself, then you are not in a position to make the decisions you want to make. So it's important to speak with your family because often family members don't all agree. You may not
Correct.
want to be intubated, and your loved ones may think that you have to be. But if you have the documents or you've got the healthcare proxy who gives the right to someone specific to make decisions for you, it helps get rid of those barriers. And frankly, it makes it easier for the family because they're not sitting there saying, what would mom have wanted?
Right. I think we're kind of preaching to the converted here. So,
Yeah, true enough. I think Richard has a question though.
yeah.
Very brief comment in liking the idea, not wanting to get too far into the specifics today, just so that we have a chance to talk to people who aren't at the table, aren't at the meeting today, who would be significant players in putting some kind of resource fair together.
Fair point.
I'm also aware people were talking some about the event that happened last year. I know that people from our sister organization, WICOA, played a major role in that. Whether they're ready to talk about and they're at the table here today, whether they're ready to talk about what they're thinking about doing this year so that we're all pulling in the same direction. I don't know, but I think that's a conversation we should have before finalizing.
Right.
So,
yes.
Can you hear me? Can everyone hear me?
Yes.
Yes, okay. I have a quick question.
Okay.
Erwin Fernandez speaking again. How do you actually get people to the table? Because it seems like the conversation, maybe the last 5 minutes assumes that the people are already at the table, and even if they've already made the decision to speak about the topic, despite the topic, being something either controversial, maybe a little personal. But how do you get over the hump of getting people to actually want to talk about it? And like, let's say we set up the resource fair, and we're going to speak about the people who are there are very likely more open to talk about this. But what about the people? How have you gotten over the hump of getting people to open up about this topic so that we can get them to come out and inform them and raise awareness about the issue? So
I don't think we've gotten over the hump. There's some things we're working on now that hopefully will help with spreading the word. Hopefully, seriously, I've brought him up twice already. Jimmy Carter has hopefully helped raise that dialogue. Richard and Dory have graciously invited us to ARC to speak to their population of members and attendees to be in an environment where people can talk about end of life care in a more sort of reasonable setting, if you will. Not a drive-by at a. I think the most we can do is try and whet an appetite or let people know. I don't know that the resource fair is going to, maybe we can give out cards about the caregiver resource that we have. There are things like that we have, but
okay.
You are right. We need to, and continually seek opportunities to speak, Miriam and Rosie, et cetera, to speak at events whenever we're invited, or whenever we can sort of push our foot in the door and explain the value. To congregations, to church, to churches, to synagogues. There's a lot of religious, misconceptions about how hospice does not sync up with religious beliefs, and there are that can be addressed pretty much across the board. We are respective of cultural beliefs and practices around end of life, and provide end of life through the care through the lens of the patient and their family.
Thank you.
So,
I wanted to add something. A lot of this end of life conversation.
There's a queue. I'm next.
Hold on. Sorry.
So
Liz.
I hear what you're saying. I think that having in the very unexpected context of a health resources fair, to have people talking about living wills, organ donations, healthcare proxy, hospice care, all of those things. And I'm not putting it all on MJHS. There are a number of people who have expertise in these areas, but having people who have expertise in all of those areas and actually talking to people in a casual social setting about these very heavy, very important topics, that's how those conversations then begin to happen. I'm totally serious when I say we need to normalize talking about death. I talk about death all the time.
I don't disagree with you at all. I think it's a layered approach that does exactly what you just described, as well as providing venues where there can be longer conversations and group discussion and people can build on it. I don't think it's one or the other. I think it's a very much a layered approach.
Right, rolling. Okay, Richard, I see your hand again.
Yeah, I want to clarify something and then comment a little bit. Are we especially focused on an event focused on hospice and end of life issues, or are we focused more on a broader resource fair around the issue such as older?
What I am proposing is that in the course of doing a resources fair, we make sure that among the people offering resources and tabling are people with these areas of expertise. I am not proposing that we have a fair limited, that we have a fair limited to end of life issues. I'm proposing that those things be among the things that are offered and addressed. Blood pressure checks, blood sugar checks, safe at home, FDNY, whatever are all of the usual suspects. And also these things that we were speaking of earlier, because part of the reason why, people don't know what they don't know. And if amidst, coffee, donuts, and balloons, there's also these nice people talking about this otherwise heavy subject in a way that is normal and conversational and social, you accomplish two things. One, you get out information about the thing that you're talking about, power of attorney, hospice care, palliative care, end of life decision-making, whatever. And two, you normalize talking about death. We have to, this culture sucks at talking about death and dying, and we have to get better at it because everybody will benefit, because newsflash, spoiler alert, we're all gonna die. All gonna die. And we have to talk about that.
Let me, having gotten the answer there, maybe there's a second model for us to talk about here. And I think either model may make sense, which is probably a little more of a community organizing model. Why don't we look at the possibility, with end of life issues being something that we're putting some additional focus on at this point, how to have a series of smaller community conversations, perhaps in places where these conversations haven't happened over the next few months, build that all to a more public event, perhaps in September.
I don't understand why we need to make it more difficult. I mean, and there's nothing in what you've suggested that negates in any way what I'm suggesting. I'm building on the idea that we had talked about wanting to have a resources fair outside in the plaza So what I wanted in raising it now, what I wanted to make sure that we did was not wait until March to say, hey, let's do this in April. Not wait until April to say, hey, let's do this in May. It's January, let's start the ball rolling now. And I think just raising it is enough, but let's start the ball rolling now so we can figure out how to have a nice event in April or May or June or whatever. And also make sure that among the resources that we include are some of the resources that speak to the issues raised in the presentation earlier. That does not preclude in any way having larger other community conversations around these issues at some future point.
Just to wrap up, nothing's contradictory or competitive in the different ideas that are on the table right now.
Yeah,
And I will keep it to that brevity.
Okay, Miriam, did you still want to jump into this?
I just wanted to say a lot of the conversation, as both Richard and Liz are highlighting, is about healthcare competency, people and literacy. People need to know what's out there. So that's one of the things we want to offer them. And then the other concern that I forgot the gentleman's name, he's there, you're there in person. How do we get people to the table? That's one of the challenges that we face when we go out into the community. And we have found that engaging community leaders as well as faith leaders who have already experienced with their community members and who have gained their trust, if they can collaborate with us in telling this is important information, this is not in conflict with our religious beliefs or with cultural taboos. And I think if we all hold hands in one large circle, then together we can make sure that community members are excited and not afraid and feel that the participating agencies are trustworthy and are not there just to sign up people to their relevant, to their specific agency services. So I think if we broaden the circle of our outreach and go to leaders that are established in the community, be it religious or lay leaders, they will kind of give an endorsement and they will say, it's okay to join, come, you will get information that may be helpful to you and your family and your loved ones.
So
I think we're good.
I think we're good on that.
Can I ask one question?
Yes.
Just in terms of wrapping our heads around possible dates, so you're gonna talk to,
I'll go next door.
yeah, and find out,
What the
but,
thoughts are, I don't know, because
and
Justin's,
not a question that
Yeah.
needs to be answered now, but just wrap your heads around April, May, June. Do we have preferences? Do people, just if folks can look at their calendars and see what other events they may be having or they may know about, to see if there are, I think Passover's like the second week of April, so I think that's not really an issue. But if people could just kind of look at their calendars and see if they've got preferences, thoughts, input, so that next month we can spend some time sort of taking the next step of planning this so we can have a good event.
I can just say that, remember, the Armory has the exercise group on Tuesdays and Thursday mornings. And that's 200 people.
Okay. So then
potentially might want to come
sure. So
to
then
this event.
Yeah.
So we want to think about the timing because that starts at
Right.
That's from 10 to 11:30. we may want to think about an alternate day rather than the first Thursday,
Okay,
so that
okay.
it could.
Yeah,
come,
we can
you
have
know.
that conversation next month,
Yeah.
but yeah.
Yeah.
Okay, cool.
All right, so I will look into any plans by the, my brain is stopped functioning. The DA's office, I'm sorry, and their, wellness fair that they usually try to have once a year, so see what their plans are for that. Future speakers, I'm hoping I'd have to get a hold of Catherine and see what's going on with Columbia. This business with the
Rehab unit.
shuttle, you know, the Columbia shuttle with, you know, by the Academy bus that was, presented at the Traffic and Transportation Committee meeting. That says that seniors and disabled in the community can
Right.
ride that shuttle for free.
Okay,
We need more information about it. I tried to get them to present for this meeting, but it's Columbia that needs, Columbia Transportation Department rather than Academy that needs to do the presentation here.
I see.
So we're trying to work that out for
Okay.
a February meeting.
That would be great, 'cause that's a really useful service.
And hopefully we'd have it in perhaps the Riverstone Senior Center, because I want to have it in an area, try to have it in an area that they will be servicing. So working on that,
Got it.
because I think that's, you know, really an important thing. Since
Yes,
nobody in the community seemed to know about
yes,
the
yes,
shuttle
yes.
being available to the seniors and disabled in the community. So
Do we have like a point of contact or a go-to person?
I can't hear
Sorry, do we have a point of contact or a go-to person at Columbia Transportation or a kind of?
it. Yeah, well, yes, Catherine has been in touch with them.
Oh,
and
okay, got it.
yeah, so I'm gonna see what her progress has been.
Cool, thank you. That would be super useful.
Yeah. Beyond that. I don't have any other announcements. Anybody else have any announcements?
No, I think we're good.
All right, our next meeting will be February 6th, 2025.
Yeah, it'd be great if we could have it somewhere else.
Yeah. Yeah. I just don't want to have it sort of, you know, off
Could we have it as Isabel?
in another land. I want to have it where the Columbia shuttle is going to be functioning so that the
Oh, yeah,
seniors hear, you know, the actual presentation and can take advantage of it.
right, right, right.
That
Okay,
people
so
can come
maybe,
to that place. That's why I'm thinking Riverstone.
yeah, that would be great. If we could do Riverstone next month and maybe, Isabella.
So we're gonna
Oh,
try switching over starting February to Waikoa. And let's see how that goes. It'll be the first time we're bringing community board meetings or community meetings back into Isabella.
Got it.
Let me just make sure that that goes smoothly before we talk about getting another one in, please.
Okay, that's fair.
Thank you so much.
Yeah.
Cool. Motion to adjourn?
All right.
Second.
Meeting is
Sweet.
adjourned.
Thanks,
Thank you
everybody.
all.
11 a.m. Thank you, everybody.
Thank you.
Right. To be
Thank you, everyone.
continued.
Thank you.
Here you